Thank you very much, chairpersons, and I'd like to thank Inazal and Professor Ajay for inviting me to come and give this talk to your esteemed audience. So my role is to talk about novel therapies, and I must say, after listening to all the MASLD talks, I'm unfortunately sad to report that we're far behind MASLD. We only have one phase 3 study in hepatitis B. These are my disclosures. So the first thing I'll talk about, the new objective of treatment is cure. And Professor Agarwal has really talked about initiation of antiviral therapy. Unfortunately, antiviral therapy, as in nucleoside analogs, doesn't really lead to a cure, except for about 1% of patients. So what is the definition of cure? And the Hepatitis B Endpoint Committee has defined this as functional cure. Now, what is functional cure? Your S antigen needs to be negative by serological testing, with or without antibodies, and your DNA needs to be negative, 6 months being off therapy, being off nucleoside analogs or any other antiviral therapy. Hopefully, this can be achieved in 30% in phase 3 studies. Now, absolute or functional cure is, absolute or complete cure is the absence of cccDNA. I'll explain what that is in a minute. And the absence of integrated HBV, which is extremely challenging. And this seems to be unlikely, although gene editing seems to be moving very rapidly in this area. Now, is functional cure a good target? And this is a meta-analysis published a few years ago that shows actually you have a significant reduction in liver-related outcomes, liver decompensation, liver cancer, liver transplant or death or first clinical event by about 70%. So it seems that this is a validated outcome and this is a good target for us to look at. Now the challenge is the complex life cycle and the complex natural history of hepatitis B. So there are really two pathways when you look at hepatitis B. There's a replicative pathway which is measured by hepatitis B RNA and DNA, and this allows the virus to replicate effectively. But actually, there's the S antigen pathway. This pathway is the production of the envelope or the surface protein, and this is produced in excess by as much as 100,000 compared to a replicative virion. So the problems with the virus is that cccDNA is a mini chromosome. I've not heard of a chromosome being able to be removed from a liver cell, so that'll be very challenging to do. And there's also viral integration, and the production of S antigen 5 in excess as subviral particles probably leads to impairment of the immune response. And active replication leads to flares and liver disease, so the use of antivirals is not had much impact on S antigen loss. The opportunities are that antivirals can produce block replication effectively, and now the biomarkers listed here are able to distinguish which pathway is being affected by hepatitis B. And this is what we're going to look at in the new novel therapeutics comes. So when I look at the overview of new therapeutics for hepatitis B, this has been a salad of multiple antiviral agents and immunomodulator patients. And the fact that there's so many targets tells us that nobody really knows which targets are likely to lead to an effective therapeutic response. So I've simplified this recently. We published this last year and it's already out of date. But here it is. There are really 3 strategies for simplification purposes. There's the inhibiting of viral replication, and this includes 2 major categories. These are the capsid modulators and the nucleoside analogs. As I mentioned to you, nucleoside analogs and capsid inhibitors don't really lead to significant reduction in S antigens, so it's unlikely to lead to functional cure. On the other hand, strategies to lower viral antigen reduction here, I'm going to look at primarily translation inhibitors and RNA destabilizers and transcription inhibitors as the backbone that's emerging as the new therapeutics. When we're looking at immune responses, we're seeing a lot of potential candidates, both adaptive and innate immune inhibitors, as well as monoclonal antibodies. And I'll focus on some of the ones that really have gone into phase 2 clinical trials with promising results. Now, the question here is, what should we be measuring when we're looking at patients trying to achieve functional cure for these new therapeutics? Should we be looking at the proportion of patients with S antigen loss or the reduction in S antigen levels? And I put to you that reduction of S antigen levels is probably more important. If you have a patient with 100 IU per mil of S antigen at baseline, and your drug leads to a 2-log reduction in S antigen, everyone will become S antigen negative. But if you're starting with a baseline of 100,000 IU per mil, then nobody will achieve S antigen loss. So this heterogeneity in baseline factors is an important outcome that we should look at. And I'll mention more about this during our novel therapeutics. Here's a quick summary of the landscape we're looking at now. I'm sorry for the abbreviations here, but you can see that most of the new therapeutics, with or without nucleoside analogs, lead to a very small reduction in S antigen, less than 0.5 log reduction, including therapeutic vaccines. Whilst the other end of the spectrum, in purple here, more than 3 log reduction are really only antisense oligonucleotides, with or without nucleosides, and nucleic acid polymers with interferon and nucleoside analogs. And siRNAs are somewhere in between. So let me go and talk about RNA interference, which now is considered to be the backbone for novel therapeutics. And there are two agents in this class here, the antisense oligonucleotides and small interfering RNAs. All small interfering RNAs are GalNAc conjugated, so they're liver targeting, while antisense is not liver targeting and they're naked. So the mechanisms of the actions is also different. The siRNAs work through the RISC complex, it's a double-stranded RNA, whilst the antisense is a single-stranded, and it works through probably RNA activity. Now, although this is theoretical, actually it has important implications in its clinical efficacy. So this is the antisense produced by Glaxo that was published in the New England recently, and this is a summary of their efficacy in this phase 2b study. So it's called bepirovirsen, and if you look at orange here is the treatment that was given weekly, 300 IU for 6 months, and that had the most efficacy, arm 1. And you can see at the end of treatment, you had 28% patients with S antigen loss. Quite a remarkable achievement. But in green here, 6 months off bepirovirsen, that rate has dropped from 28% to only 9%. And in fact, the patients who are not on nucleoside analogs had actually a similar response. So nucleoside analogs didn't add any benefit to the activity of bepirovirsen. They found that if your S antigen level was less than 3,000, your S antigen rate, loss of rate of S antigen was as high as 25%. So a low S antigen level seems to be more efficacious than a high S antigen level. Now, contrast this to siRNAs. These are two siRNAs. This is one from Arbutus, and this is one from J&J, who are no longer in the market. And you can see that the siRNAs have about a 2-log reduction in siRNA, and here 2.5-log reduction in S antigen levels. But if you look at the efficacy of the drug after you come off treatment, there are only 2 injections given here. Off treatment, the S antigen levels remain low and they don't rebound compared to the antisense. Compared to the J&J, you have a similar response. There's a very slow increase in the S antigen levels even after coming off therapy. Unfortunately, no patients achieve S antigen loss. So that's the contrast between these two agents and efficacy. What about the role of immune modulators? Well, this is quite an old study looking at the Gilead TLR8 agonist, selgontolimod. Is a phase 2b study, and there were two doses, 1.5 and a 3 milligram. 3 milligrams in blue here, and 1.5 milligrams in green. You can see that after 48 weeks, there's a heterogeneity in response. Some patients actually had a very good response, and some patients had a very poor response. But if you look at the scale here, the response rate is less than 0.5 log in terms of S antigen reduction. So even though two patients had S antigen of 5%, the actual reduction in S antigen levels were actually relatively small. In fact, when you look at the paper, there was no significant reduction in S antigen levels on these two drugs. PD-1 and PD-L1 is now the mainstay of oncological therapy for HCC. So people have thought that this would be a good strategy for patients with chronic hepatitis B as well. And this study was done, in fact, with a new drug, evanfolimab, in patients with S antigen levels of less than 100 IU per mil. So this is a highly selected population of patients. And when you see the efficacy of this group of patients, you have a 21% S antigen loss. Only 4 patients lost S antigen. But here's the worry. 17 to 36% had thyroid dysfunction, 20% have rash. So the limiting factor for these checkpoint inhibitors may be adverse events of thyroid dysfunction. Therapeutic vaccines have really been thought to be a novel therapeutic that could really reduce the side effects, at least boost immune responses, and lead to better rates of S antigen loss. In this study, they combined it with a PD-L1 inhibitor, nivolumab, and you can see that there's a complicated trial using the new Oxford chimpanzee adenovirus and modified vaccinia and caravirus viral vectors, and combined with nivolumab. In green, this is the Chad Ox prime followed by the boost with nivolumab, and then with a second dose in day 85. You can see in green had the best responses here, but what we can see here that only 19% had undetectable S antigen greater than 16 weeks, and there were only 2 cases. And all these patients had an S antigen level of less than 200 at baseline. So even in the best possible responders, you had a relatively low S antigen loss rate. Again, this is due to nivolumab. 9% had thyroid dysfunction, although this resolved in most of the cases at the last visit. So what are combining RNA interference and immunomodulators? How would that work? So this is the study with the bepirovirsen, the GSK drug, with interferon as a sequential therapy. And you see here in yellow, the best responders are those who had an S antigen level of less than 1,000, and 24% in arm 1 and 40% in arm 2. However, we should note that the ones who had a longer bepirovirsen actually had the lowest response rate, again indicating this heterogeneity in responses. Overall, the result of these treatments is that the conclusion was that really the addition of interferon led to fewer relapses in S antigen. It didn't lead to any increased S antigen loss, but just fewer relapses, so that the sustained response was preserved. If you combine siRNA with interferon, how does that work? You need basically in this study, using the VIR-2218 siRNA, you need to give more than 44 weeks of interferon to see that response. You see, if those interferon is given for less than 44 weeks, you get either a sustained suppression of S antigen, or you get an increase in S antigen levels. But after you give more than 44 weeks, you actually get a reduction of S antigen of more than 2.9 logs. And here, then you have patients who have increasing S antigen loss of 31%. So interferon and siRNA needs to be maximized. You need to give a longer duration of siRNA, longer duration of interferon, for you to get S antigen loss and significant reductions in S antigen. How does a TLR7 agonist compare with interferon? This is a Roche study, Paranga, and here it's a 4-arm study, and I want to highlight these 2 arms here. This is Rizolimod, is a TLR7 agonist together with zalnisaran, which is a siRNA from Roche, combining with a nuke, and instead of a TLR7 agonist here, you substitute with interferon. You can see here that the primary endpoint was achieved in 12% with TLR7, but 23% with interferon. Again, small numbers of patients, but it seems to indicate that interferon works better than a TLR7 agonist. So we still haven't found a good immune modulator to replace interferon. I'm sure all of you will know the old days of hepatitis C. We had to use interferon until we found better drugs that could do the job. Now, what about using an siRNA and a therapeutic vaccine? This is imdusiran together with therapeutic vaccine VTB300. I've told you about VTB300 already. It's chimpanzee adenovirus and modified Ankara viral vector. And you can see here that the addition of therapeutic vaccine didn't actually increase S antigen loss, but actually it reduced the relapse rate. In the placebo arm, quite a few patients relapsed, but in the VTB300 treated arm, there was no relapse. So it seems that the role of immune modulators may be to reduce the possibility of relapse. So I've given you a lot of data, and I haven't shown you everything because really there's too much data to summarize, and a lot of phase 2B study with small studies. But here's a general takeaway messages. Antisense leads to a 3-log reduction. You can get 9 to 10% S antigen loss, regardless of nuke therapy, but a rapid rebound in non-responders. While an siRNA leads to 2.3 to 3-log reduction, and sustained S antigen suppression of therapy, but no S antigen loss. For immunotherapy, success is limited, and most of the success comes in patients with low S antigen levels. Interferon, you need possibly less than 1,000 IU per mil of interferon to see it having some efficacy. Therapeutic vaccines, you need less than 200. Checkpoint inhibitors, less than 100. Other than interferon, immunotherapy reduces relapse rate, but not too much increase in S antigen loss. Now, we just came back from the Singapore Hepatology Conference and the Science of Hepatitis B Cure in Singapore just a week and a half ago. And here's the conclusion from our cure meeting. Functional cure is not virologic cure. We can still detect cccDNA in patients with S antigen loss. There's a heterogeneity of patient characteristics and responses that makes strategies challenging. So preferably, you should have more than 50 patients in your phase 2 studies so that you can be more confident of the efficacy of your results. And most of these studies have actually only about 20 patients in their arms. Immune biomarkers correlate poorly with antigen loss. We still have good immune biomarkers today. Interferon, you can see, has made a comeback. It seems to be the dominant backbone for immunotherapy. So this is my closing slide. There are challenges and opportunities. The challenges seem to outweigh the opportunities at this time. Complex natural history, can't remove cccDNA from the nucleus. S antigen is produced by viral integration. Immune mechanisms of S loss are not well understood. Existing therapies have limited efficacy in S antigen loss, and immunotherapy efficacy is better in those with low S antigen levels. So these are the challenges. Opportunities are that I didn't show you this data, but stopping nucleoside therapy can actually lead to S antigen loss in up to 30% of patients with low S antigen levels. But again, these are selected patient populations, and agents active in reducing S antigen levels are now in clinical trials. Antisense and siRNA are the most promising agents and likely to be the backbones for future therapy, and you can build combinations upon this. The first trial combining antisense and siRNA actually will begin this year, and that will see whether we can get above that 30% threshold, hopefully about 50% threshold. And immunomodulators will be combined with such agents. quite likely there are multiple paths to achieve functional cure, and we look forward to see what the data shows us. And of course, please come to Singapore for the Science of Hepatitis B Cure next year and the Singapore Hepatology Conference, August 22 to 24. Thank you very much for your attention.